Okay, it's really exciting to see this conference take shape, the first meeting of the International Society for Evolution, Medicine, and Public Health. Very exciting moment for us. I want to acknowledge the other members of the program committee. Cynthia Bell is one of them up here in the front, and Randy Nesse. And we had really quite an amazing and exciting experience planning this program. We thought we'd be lucky if we got about 80, maybe 100 people. I think many of you know we're now well over 250, closer to 300 actually than 250. So an amazing turnout from people around the world, really people from everywhere. We have people obviously from Europe, many from Australia and New Zealand, and of course all over the United States. So it's really an exciting moment. The other thing that was really fun was trying to figure out ways to bring more junior people and to get them involved in the society. And I think if you look around, you're going to see that there are many junior scientists, graduate students, postdocs, and assistant professors who are here in the audience and who are really wanting to be a part of this society. And I'd really encourage everyone to talk with them and to encourage them in their efforts. The people, though, who really deserve a lot of the credit, I mean, we had a lot of fun on the program committee, but it's really the organizing committee that deserves most of the credit for this, and they've been amazing. Again, Randy Nesse's part of that, but Kathy Holliday, I don't know where she is at the moment, but in the back, please thank her for her great contributions, as well as Lenora Ott. Lenora, there's Lenora, okay. And other members of their team, Jacqueline Smith, and there are many other people who are involved that I'm not even aware of, but they've worked tirelessly to make this happen, and they really deserve your appreciation at some point. Why don't we give them a round of applause to thank them for all that. Okay, so our first speaker is Dr. Barbara Natterson-Horowitz, who's currently at UCLA. She's a cardiologist there. I think many people know Barb and her work and the amazing impact it's had at bringing together veterinary sciences and medical sciences and the incredible insights that she's generated. So as I said, she's a professor of medicine at UCLA in cardiology. She's also an adjunct professor in ecology and evolutionary biology at UCLA, and she's co-director of their evolutionary medicine program. So she's someone who's really crossed the boundaries between an arts and sciences and medical school departments and schools in a university, which is really incredible. And in addition, she's a consultant at the LA Zoo, which is where many of her insights really originated in her work at the LA Zoo, consulting with animal health there. She was an undergraduate at Harvard and got a master's degree there as well in history of science, and then went on to University of California, San Francisco for her medical training. She's very well known for her outstanding book, Zoobiquity, which really, as I mentioned, has had a huge impact on the public and also for scientists with the subtitle, The Astonishing Connection Between Human and Animal Health. Really a great book. If you haven't had a chance to read it, I'd highly recommend it. And her insights have appeared in many prominent places in the popular press, for example, NPR, New York Times, Wall Street Journal, and others. And if you haven't watched her TED Talk or listened to some of these interviews, I'd highly recommend it. They make great materials as well for sharing with students in a class. So with that, I'd like to welcome Barb as our first speaker.
Well, thank you. Thanks, Charlie. Thanks to the program committee, the conference organizers, Randy, Cynthia. We have a great couple of days ahead of us, and I'm really honored to be the top of the batting order. So I'm going to talk to you today about how important comparative medicine is for any conversation about evolutionary medicine. And I'm going to do that by telling you my own story. Well, 10 years ago, I was a cardiologist practicing at UCLA. I'd been there over 20 years. And like a lot of physicians in academic medical centers, I had become very specialized. I had finished medical school and specialized first in internal medicine. Then I had done a cardiology fellowship. Then I had done advanced training in cardiac imaging. And it was about 10 years ago when my story really begins. I had just narrowed down and had become director of our cardiac imaging project there. And I remember this because this thing that happened, which I'll tell you about in a moment, happened while I was working on a project looking at developing small catheters mounted with an ultrasound camera to place in the pericardium of patients who were undergoing radiofrequency ablation, using that catheter to image the catheters that my other cardiovascular colleagues had in the left heart and guiding them to the connection between the pulmonary veins and the posterior wall of the left atrium. That was the last paper that I had published when this thing happened. It was very, very deep and very narrow, my focus was. And then I got a telephone call that really changed my life. And the call came from a veterinarian at the Los Angeles Zoo. They were wondering if I'd come to the zoo and do some imaging on some of their grade 8 patients and ultimately some other patients. Now I should tell you that zoos and aquariums in North America, they are staffed by highly qualified board certified vets who take outstanding care of their animal patients. But occasionally veterinarians do reach into the human community, particularly the medical academic community, for subspecialty assistance. And I was frankly just the lucky physician who got that call. And over the next couple of years, I had the opportunity to rule out an aortic dissection in a gorilla, assess a macaw for a heart murmur. There was a California sea lion that they were concerned had constrictive pericarditis. There was lower body edema. And in this picture, I'm listening to the heart of a lion after a collaborative procedure in which veterinarians and human physicians drained the pericardial sac of about 700 cc's of serous sanguineous fluid. This lion was in cardiac tamponade. The physicians in the group know what that means. And that procedure, which was ultimately, we did a pericardial window, and I've done that on many human patients, and the procedure was identical, with the exception, of course, of this and the tail down here. So there's one patient that really sparked this whole journey for me, and it was a chimpanzee. There was a chimp who had woken up with what they thought was potentially facial asymmetry, a facial droop. And they asked if I'd come to the zoo and perform a transesophageal echocardiogram to look for a cardiac source of embolic stroke. So when a human being wakes up with a facial droop, we grow concerned that there could be blood clots or something else in the heart that could be showering into the brain, and we do this procedure, and I do many of these every week at UCLA. But I remember when I first came to do a TE on this patient, she was sedated and intubated like many of my human patients who are going to undergo this procedure, and it was exciting. I walked over, took the probe, put it in the chimp's mouth, placed it down her esophagus to the proper position, and this is what I saw. It was a 4-chambered beating heart, a left ventricle, right ventricle, left atrium, right atrium. But immediately I noticed there were some abnormalities. There was thickening of the left ventricular free wall, the interventricular septum. Both atria were enlarged. And here you can see in the right atrium these bouncing balls. These are blood clots. And I recognized that this chimpanzee had a form of infiltrative cardiomyopathy, a disorder that I've taken care of in human patients over decades. And in all of the cases that I had seen, I could never remember, there was not a single instance in which anyone, my teachers and ultimately my colleagues, had mentioned a non-human animal who spontaneously might have developed this disorder. And what was really remarkable in that moment was that echocardiogram reminded me nearly identically of a human patient that I had imaged some weeks before who also had this infiltrative cardiomyopathy. Now, I started thinking about the connection between animal and human health, and I went back to what I had learned in medical school. If you ask most physicians today, what is the connection between animal and human health, the immediate answer they'll give you is zoonoses. So these are infectious diseases that pass between the human and the animal reservoir. These days, they would probably talk to you about the fact that the majority of the emerging infections which are affecting human populations come from animal reservoirs. We're talking about Ebola and West Nile, etc. But I was going to the zoo, and I was listening to the veterinarians on rounds talking about leukemia in one of their patients, and anxiety disorder, and hypothyroidism. And so I started getting curious about how many of the disorders I was seeing in my patients on rounds at a busy teaching hospital, veterinarians were also seeing in their patients. And so I asked a series of questions, and a summary of those questions is right here. Do animals get breast cancer? What about congestive heart failure? What about Crohn's disease and other inflammatory bowel disease? Diabetes type 1 and type 2, atrial fibrillation? What about melanoma, glioblastoma, leukemia, lymphoma, etc., etc.? And the answer to every one of these questions, of course, was yes. I began extending after about 6 months the questions to include biobehavioral disorders. And so I asked, do animals get separation anxiety, compulsive disorders, self-injury? What about eating disorders, age-related cognitive decline, addiction, hallucinosis? And again, the answer to those questions was yes. So now I have given a form of this talk to many groups of physicians and veterinarians, and there's an important difference in the response. When I show these slides to groups of physicians, and that yes comes up, there is laughter very often, there's buzz in the room, there's conversation. For the most part, this is news to physicians. But when I show these same slides to groups of veterinarians, as the yeses go up, I see them looking at each other, and I even heard once an audible duh. This is what veterinarians do. The problem is there is a gulf, there is a gap between human and animal medicine. It is real, and there are consequences to that gap. I've wondered a lot about why it exists, and there are several possible explanations. Maybe we can blame Descartes. Maybe this is a 300-year-old legacy of that Cartesian duality between man and animals. Maybe it's human exceptionalism, or maybe it's just underexposure of our profession to animal science. What's notable is that some of the fathers of modern medicine, certainly father of modern pathology, Virchow, seem to understand this connection better than we do today. In the 19th century, he wrote, between animal and human medicine, there's no dividing line, nor should there be. The object is different, but the experience obtained constitutes the basis of all medicine. And one of Virchow's pupils was Sir William Osler, who's considered a father of modern medicine. And he actually, you see him performing a bare-handed necropsy here, and he was one of the founders of McGill School of Veterinary Medicine. But things have changed, and unfortunately this gap, this gulf, is very real today. And I've spent now the last about 7 years exploring this gulf and working to close it. I've done that in a couple of different ways. One was to write this book. I worked with a brilliant science writer named Catherine Bowers, and together the two of us tried to explore how human medicine could be improved if we began looking at the human patient as a human-animal patient. In addition to the book, I've started what are called Zoobiquity conferences. And these are conferences where we bring together medical schools and veterinary schools, and we have senior faculty discuss cases that are shared by animals and humans. This was a photo taken at our first Zoobiquity conference. This is the Dean of UCLA School of Medicine, and this was the Dean of UC Davis School of Veterinary Medicine, Benny Osborne, at our first Zoobiquity conference. At these conferences, we present comparable cases. So we will have a veterinary cardiologist present a case of atrial fibrillation in a gelded Appaloosa, followed by the presentation by a human cardiologist of atrial fibrillation in a pilot, one of my patients' EKG. And then we have the DVM comment on the human animal and the MD comment on the animal. And then our audiences, which are about 50-50 DVMs and MDs, engage in a comparative conversation. And we look at cancer and heart disease and biobehavioral syndromes, etc. We've had 5 now in the United States. Our next is going to be at Boston Zoobiquity in April, hosted by Tufts Vet Med, and we have all of the medical schools in the Boston area participating at a pretty high leadership level. We've also now, there's been a Zoobiquity Australia and one in Europe as well. Well, how does all this comparative thinking help change medicine? Does it? What kinds of scientific or clinical insights can come from this? About a year after I started going to the zoo, I was called to image a little tamarin monkey whose name was Spitzbuben. Spitzbuben, they were concerned, was developing congestive heart failure. A number of the other tamarin at the zoo had developed heart failure, and they wanted me to image her heart to see whether the function of the ventricle had weakened, whether it was decreasing. And if it had, we would start her on beta blockers and ACE inhibitors and all the things we would give a human patient with early stages of heart failure. And so I came to the zoo that day, and they had Spitzbuben in a little box with a clear plexiglass front. And I walked up very close. She's a beautiful animal. I walked up close to her, very close, and I crouched. And what I would do with a pediatric patient or with my own child, it was an attempt to connect, to demonstrate care, and she was beautiful and compelling. But as I did that, the veterinarian, I felt a hand on my shoulder and I was pulled back and I was scolded. It was an admonition: stop looking at her so closely, move away from her, you're scaring her, and you're going to give her capture myopathy. I heard that, and for the medical people in the audience, myopathy, disease of the muscle, we see myopathies all the time. But capture myopathy, that's something that I'd never heard of. So I went home and I read about capture myopathy. And it turns out a wide range of animal species, when they are quite scared, typically in a pre-predation situation or with capture, let's say a wildlife biologist is tagging them, etc., they experience this massive sympathetic efferent from the central outflow from the CNS. They have a rise in their circulating plasma catecholamines, and this results in injury to the skeletal muscle and also sometimes the cardiac muscle. It can result in a decrease in their cardiac function, heart failure, and in some instances, even death. And this has been described, as I said, in a wide range of animals. It's been seen in shorebirds on various continents, in lagomorphs, little hare. And actually it's been described in many species of ungulates. Now, why is this interesting to me as a human cardiologist? Well, for a couple of reasons. First, there is a syndrome in humans called the broken heart syndrome. And this was described not too long ago. And this is a situation, we see this in patients who've experienced extremes of stress. They've witnessed a loved one die. It's been described in a man who lost his life savings at a casino. It was actually described once in a woman who was left at the altar. So these are extremely intense, adrenergic, catecholamine-inducing scenarios. And these people have chest pain and acute heart failure at about 5% mortality. It's also notable that it was described in the veterinary literature, this syndrome, capture myopathy, decades before it appeared in the human literature around the year 2000. So the similarity was interesting to me. And by the way, this has been seen not only in individual patients, but there are population effects on which we see it. This was published in the New England Journal a couple of years after January the 17th, 1994, which was the date of the Northridge earthquake, which was the last major earthquake that we had in Los Angeles. I remember it well. I was a few months into my chief residency in internal medicine, and our ER turned into kind of a war zone. But you can see, comparing the rates of death on January 17th, 94 versus 93, 92, and 91. The effects of fear, of high intensity adrenergic stimulation on cardiovascular death. So I started getting really interested in this comparative perspective, and that led me to wonder about what the evolutionary connection might be between acute sudden death, let's say capture myopathy or cardiovascular capture myopathy in animals, non-human animals, and humans. And to explore that, I one day walked out of the front of Ronald Reagan UCLA Medical Center on Westwood Boulevard. I made a left-hand turn. I walked about 100 yards heading north to the office of Dr. Dan Blumstein, who is the chair of ecology and evolutionary biology at UCLA, and he's here today. And we started a conversation that basically hasn't ended since that first conversation. It's just been ongoing. Because it turns out, Dan told me that he really studies something that's very similar from a very different perspective. He studies fear. He looks at the ecology of fear. And he studies marmots and other animals. But he related that he had actually also been fascinated by this acute sudden death, this stress phenomena that he had actually encountered. He described for me that the marmot, you can pick up a marmot apparently, and you can hold it tightly, you can hold it lightly, you can turn it this way, you can turn it that way. Pretty sturdy, pretty invulnerable. On the other hand, a pika, if you pick up a pika and you hold it too tightly or you hold it the wrong way, it can actually die in your hands. So he too was interested in this comparative difference. And that led him to suddenly come out with a question which was just transformative. He said, it wasn't a question, it was a statement. He goes, let's create a phylogeny of sudden cardiac death. And that's what we tried to do. And we ended up bringing in a wildlife biologist from the USGS in Alaska who had actually been collecting reports of capture myopathy and collecting literature on it. We had an electrophysiologist at UCLA, we had Dan, we had a graduate student, and we put together, you can see a very these are birds, ungulates, and mammals, a kind of messy phylogeny. The problem is capture myopathy is a kind of garbage bag term for a lot of related syndromes that are seen in association with capture. And it's hard to figure out which piece of this is the cardiovascular component. And yet the simple exercise of creating a phylogeny of sudden cardiac death immediately sparked new questions. Given this differential invulnerability to this phenomenon, doesn't it mean that there could be insights through comparative genomics? Inspired by the work, for example, of Elaine Ostrander at NIH, looking at variable vulnerability to quote-unquote human diseases in different dog breeds, could we not use those kinds of insights and apply them in the wild? Furthermore, a phylogeny of sudden cardiac death sheds new light on conventional theories about why broken heart syndrome happens in humans. So one of the theories about why this happens is that there is an exaggerated autonomic activation in response to this mental stress, and that results in an overshoot that triggers ventricular tachycardia. It's a kind of electrophysiologic version of Randy's smoke detector principle. Well, thinking comparatively and having a phylogeny allows us to think about comparing the autonomic nervous systems of animals who need to have a robust response to evade capture, who may engage in highly adrenergic, sympathetic activities like fighting, and encourages us to look quite leftward in the evolutionary timeline to the autonomic nervous systems of other animals that too must evade predators and engage in other high adrenergic effects. Well, looking for the phylogeny of sudden cardiac death inspired me to think a little bit bigger and think about a broader project to create a phylogeny of disease, really a phylogeny of disease vulnerability that I could show my medical colleagues. And at the time, I was beginning to teach a class in evolutionary, to undergraduates on evolutionary medicine. And so what we've done as a class over 2 semesters is to assign, Benison Pang is a graduate student at EEB, he and I are working on this. We assign the students human conditions. And we ask them to look comparatively and apply a variety of levels of evidence to create phylogenies for different disorders. And these are incomplete. There's a lot that's gone into how we're defining diabetes, more than just type 1 or type 2. We're really looking for vulnerability. But the mere exercise of creating a phylogeny for these disorders shifts how we think about these diseases in human patients. I don't want to spend a lot of time on the specifics of how we're developing these, and these are works in progress, except to say that we're trying to have variable levels of evidence as we place animals, both extant and extinct, on these phylogenies, and we're looking at a range of disorders all of which are common in humans: melanoma, arthritis, STDs, compulsions, endometriosis, leukemia, miscarriage, CHF, and quite a few others. And ultimately, what we want to do is to have something like this, where on the bottom we have the disorders, where we have some phylogenetic relationship that can be seen, and a document that will speak to my colleagues in medicine about the importance of thinking comparatively, evolutionarily, and I'll tell you why I think that's important. When you have a phylogeny in your head, you can think more clearly about medical problems. Here's an example: breast cancer. The breast, it's what defines mammalia. And certainly we know that any female mammal, okay, I have a, unfortunately, anyway, female mammals nurse, and that is characteristic of, sorry, anyway, I have some beautiful movies which you're not going to see of a number of species nursing. And this is a coyote that was a California coyote who was nursing her pups. The point is, a breast is a breast is a breast. There are mammary glands, milk ducts, etc., and breast cancer has been seen in a wide spectrum of wild animals. We're talking about spontaneously occurring breast cancer in both domestic and wild animals. A wonderful paper was written by a veterinary pathologist named Linda Munson, who was at UC Davis. And unfortunately, Linda passed away a couple of years ago, but some of her graduate students have continued that work. And in fact, breast cancer has been seen by necropsy in wild wallabies and kangaroos, beluga whales, jaguars, tigers, koalas, ferrets, sea lions, etc., etc. And it's notable that there are some animals that, some wild animals rather, in whom it's seen more commonly than others, and I'll get to that in just a second. Well, there are some humans who are more predisposed to breast cancer than others, and many of you will remember that a couple of years ago, Angelina Jolie went public with an announcement that she'd undergone a prophylactic mastectomy because she carried the BRCA1 mutation, and her mother and her aunt had died of breast cancer. And this put into the public eye the BRCA1 mutation. The BRCA1 gene acts as a gene repair mechanism. It's located on chromosome 17, and when it is mutated, it predisposes patients to develop breast cancer. Having a mutated BRCA1 increases the risk from 1 in 10 to about 6 in 10 in human populations. Well, the BRCA1 gene is present in many non-human animals: manatees, rhinos, orangs, camels, pandas, whales, etc. How common the BRCA1 mutation is in these animals is unknown, but we do have some evidence that jaguars, particularly Venezuelan jaguars, and these are captive jaguars, and many of them have been treated with progestin-based contraception, but they have a very high incidence of both breast and ovarian carcinoma. And it turns out some of those jaguars do in fact have a BRCA1 mutation, as do certain dog breeds who have a high rate of breast cancer as well, certain groups of English Springer Spaniels, for example. Well, not only does creating a phylogeny point to animals who have increased vulnerability, but more importantly, it exposes animals who have less vulnerability. Because when we lined up all of these animals, we saw that what was missing on that phylogeny were dairy animals, what veterinarians call professional lactators. And it turns out dairy sheep and cows, females who lactate pretty much continuously from the point that they are reproductively adult, basically never get breast cancer. It's extremely rare. And that's relevant potentially in terms of developing novel hypotheses and approaches. Of course, it also conforms with the human epidemiology of breastfeeding being somewhat protective against breast cancer in humans. The point is, without a phylogeny, without this comparative perspective, this kind of question can't be asked. And the fact that there are species who seem to be more vulnerable remains unknown. I also wanted to spend a moment talking about biobehavioral syndromes, because it frankly was news to me how common psychopathology is in many different animals. Exposing the comparative perspective of psychopathology does a few things scientifically, but it does something very important socially. I think it reduces stigma. Not an evolutionary point, but a very important clinical point. For those of us who take care of patients with mental illness, we know that stigma prevents a lot of folks from accessing care. And I think recognizing that many forms of self-injury, of psychopathology from self-injury, eating disorders, anxiety, etc., happen in non-human animals spontaneously can help with that. In addition, recognizing that, for example, self-injury happens in non-human animals helps us develop new ways of thinking mechanistically about what might be going on. One good example of this, there's a human condition called trichotillomania. This is where people pluck out patches of hair. Typically the eyelashes are one of the most common targets, but people can pluck out any patch of hair. There's a fascinating, I think, corollary in the veterinary world called feather plucking disorder, and there are many behavioral similarities. What's notable from a clinical perspective is that the strategies that veterinarians use to treat self-injury in animals, I think, has translational potential to be used by psychotherapists on the human side. Finally, another kind of intriguing biobehavioral disorder is postpartum depression. And I think it's a particularly juicy target for this crowd and this conversation because there have been a number of attempts to create evolutionary explanations of postpartum depression which have not been very satisfying. And one of the problems, I think, has been a failure to recognize that these disorders are not uniquely human. That when all goes well in the perinatal, the peripartum period, there's good bonding, you have a happy mother and a happy cub, there's proper teaching behavior and bonding, and we see that in mammals and we see it in non-mammalian species as well. Well, it turns out there are a number of species, non-human species, in which things go wrong, and it's been explained in all kinds of ways, but I think it's important to realize that the neuroendocrine abnormalities that are probably accompanying infant rejection and in some cases infanticide are probably very similar to what we see in the neuroendocrine systems of women who are in the throes of postpartum depression and even psychosis. There's a syndrome that is being studied at UC Davis vet med called the foal rejection syndrome, and this is seen in mares who sometimes just lose interest in a particular foal. They refuse to nurse. They sometimes will actually kick the foal as the foal approaches, and it can result in injury and actually death. Interestingly, it's seen more commonly in Arabians and in paints, and so there is this breed-specific genetic predisposition to the disorder, which is not surprising. What's interesting is comparatively, we know that postpartum depression happens pretty frequently in about 10 to 15% of new mothers. It can be accompanied by anxiety, compulsions, even psychotic symptoms. It's that feeling of feeling nothing for the baby. And there's about a 4% infanticide rate. I understand that there's been some effective strategies using intranasal oxytocin, but the vets really had a lead on this because they've developed a procedure for foal rejection syndrome, which involves cervical stimulation to trigger oxytocin, and it's actually very effective. I was up at a breeding facility up in Northern California and talking to some vets and equine specialists who've used this. And thinking about this mechanism of peripartum depression as fundamentally connected to the neuroendocrine system and dysregulation on that level, I think is helpful and can help us prevent some of the mistakes that have been made in the past with evolutionary medicine. So I want to just begin to wrap up by thinking about how developing a phylogeny of disease vulnerability can help us think more clearly about medical problems and about evolutionary medicine. It works in a few ways. First, I think having a comparative perspective allows us to develop novel hypotheses that we simply couldn't even consider if we were unaware of these disorders in non-human animals. Secondly, I think it changes how we think about the diseases of civilization. So as an internist and as a cardiologist, I spend most of my life taking care of patients with hypertension and heart disease and cancer, etc. Well, recognizing that diseases of civilization are really about amplification of risk with our civilized practices is clarifying. You know, I want to thank Marlene Zuck for the coinage paleo fantasy, because physicians have their own medical paleo fantasies, and patients do too. That somehow, were it not for the things that we do, the food that we eat, and the lifestyles that we lead, that we wouldn't have heart failure or cancer, etc. And in fact, what we know and what a phylogeny exposes is that while we certainly do things to increase our risk of developing these disorders, the underlying substrate, the vulnerability for these disorders is quite ancient. And I think that perspective is important. Well, the final reason I think that we should create phylogenies and think broadly and evolutionarily is that it represents an antidote to the kind of super specialized, narrow thinking that characterizes much of medicine and definitely characterized my professional life before I got that telephone call. And I'm going to close by sharing with you something that I say to my med students and interns and residents when I'm attending on the wards or in the CCU. As physicians, we're asked to take care of really hard problems, the most difficult problems that human beings have. And we do that in many ways. But I ask them to remember that one of the best ways of understanding human challenges is by paying close attention to how all the other patients on the planet live, grow, get sick, and get better. Thanks a lot. Question?
We have time for questions. So I'll let Bart call.
Yes.
Thank you for a wonderful talk.
Could you stand up, please?
We really need people to use the microphone so people all around the world who are listening can hear you. Now I'm stressed. Thank you for a wonderful talk. I just want to make a comment about being very cautious about the application of some principles to humans, particularly in cases like when you discuss postpartum depression. Because I started as a biologist, continue as an anthropologist, and when you come from biology, you see that postpartum depression really is obviously a mechanism to stop investing in particular offspring, right? Because this is not the right moment or this is not the right offspring. And you immediately went to the endocrine aspects of postpartum depression and saying, we can stop this. And I wonder if that's the real solution, because what postpartum depression, not in every case, but in many cases, is probably indicating is that this woman is facing a huge challenge that may be social or related to the offspring, to the quality of the offspring. Mm-hmm. And sometimes the best solution will be to help her resolve that conflict rather than intervene at the endocrine level. Thank you.
Right, it's a great point, and thank you for asking that question. Yeah, I would say we have to be careful about what we're actually comparing, and so you make a good point. What I would say, we know from the human epidemiology of postpartum depression that it's seen more commonly when there are socioeconomic stressors, when there are life stressors, and what I would say the comparative piece would then be is to say that whatever her psychosocial stressors are activating some perturbation of her neuroendocrine axis, and that is triggering the postpartum depression. And the comparison would then be to what is happening to this animal mother-child bond that is going wrong. There's some comparable non-human stressor, but the pathway is leading to a very conserved neuroendocrine dysregulation.
Okay, Peter?
Harvey Kleiman.
Harvey, sorry.
Is it on?
It's on. Hello? Harvey Kleiman, Yale University. I was wondering if there's a phylogeny for autism and how that would work in animals. I did not see that on your list.
Yes, so autism has been one which we're very intrigued with, and I Specifically didn't put that on there for a couple of reasons. I should say there's a guy named Joe Madigan who recently got a lot of attention. He's doing the work on the full rejection syndrome, and he recently published about an equine syndrome which has elements of human autism. It's not autism, but it's got elements of it. And he has some interesting ideas about cesarean delivery versus vaginal delivery, etc. We're trying to be very conservative in our approach to the biobehavioral disorders. Schizophrenia is not up there, autism is not up there. Disorders that require thought disorder on the DSM-5, for example, are excluded. You'll notice there's an OCD. I had a phylogeny of OCD. The animal is not O, it's C. There's no obsessions. Animals have compulsive disorders. We don't know if an obsession underlies and drives the compulsion. So we need to be careful, but autism I don't have.
If I could ask a related question,
Yes.
I was wondering about sleep disorders.
Use the microphone.
Sure. I was wondering along, sort of similar lines about diseases that weren't up there, and I was wondering about sleep disorders. I mean, given that they're so common in humans, and
Right. Well, it's a fascinating and important topic. The two sleep points that are really interesting right now: brachiocephalic dogs. So those are the sort of flat-faced dogs, the pugs, boxers. They tend to have pretty high rates of sleep apnea, and they develop pulmonary hypertension as a consequence. In fact, there are certain airlines that won't allow brachiocephalic dogs to travel who have a high problem with altitude in airplanes. And so sleep disorders are seen in certain dog breeds based on that morphology. What I think is interesting is to look comparatively at normal sleep in different animal species, and we know there's a significant range, looking for natural animal models of adaptations that might be applicable to human sleep disturbance. Okay.
Neil Greenspan,
Yes.
Case Western. So in terms of breast cancer, it's a fairly complex situation at present, and there are multiple types of breast cancer which have been identified based on transcriptomic profiling. So when you put up a phylogeny of breast cancer that's focused only on one or two genes that are contributory that account for a minority of the cases, I think it's important to put that in the context of a much more complex, it's a term that has a much more complex background in terms of variation even within humans. And I think one also needs to be cautious in extrapolating from any particular animal species to human, although I agree that it's a very valuable tool to have a phylogenetic perspective, because just like we see within human beings, particular genetic variants can completely nullify the effect of a gene that in other people has a major phenotypic consequence. So, I think we have to be careful about just automatically assuming a one-to-one correspondence between what goes on in humans and what goes on in other species.
Sure, of course. What we're looking at here, this is an attempt to create. This is an idea. This isn't. The challenge, and you may not be aware of this, but most physicians have almost no awareness of spontaneously occurring diseases, even within their own fields. As I began learning about melanoma and leukemia in certain wild populations, I went to my colleagues who are oncologists and I asked them about it at UCLA, and most of them had no idea. They were very interested and they wanted to learn more, but there's been underexposure. Of course, all of these diseases are complex. We don't want to have something that's facile, but right now there's nothing to offer a medical student to say, hey, you know what, get out of your Homo sapiens-centric little perspective at the bedside and broaden out, because we aren't the only patients on the planet, and so we need a strategy. This, by the way, was crafted by my students. We had 9 students, undergraduates, who are part of the evolutionary medicine minor that Dan and I started at UCLA, who worked on this over the summer with Benison Pang. So this is not some medical document. It's an instrument that I would encourage and invite people in this room to join me in creating an accurate one.
So we'll take one last question. We have to stay on time.
Ajit Barke, UCSD. That was really an inspiring and wonderful lecture. With regard to the phylogeny of disease, I do think I agree with the previous questioner that we've got to be careful about differentiating between convergent evolution and shared origins. For example, breast cancer is extremely rare in most non-human primates. So that's just as one example. So that while we can learn a lot about studying breast cancer in other species, and it doesn't necessarily follow that they had common origins.
Of course. I mean, what's helpful are the rare diseases where there are actual fossilized, there are these lytic lesions of multiple myeloma that have been seen in a few Ice Age mammals, for example. Then you can say, you know what, chances are spontaneously occurring multiple myeloma existed back during the Ice Age. But with the exception of that, we're looking at this again as vulnerability and a broadened species spanning perspective. Thank you very much.